Dr. Garima here, and let's quickly do another Australian Dental Council exam question. Uh, yeah, have had a extremely busy week and super busy weekend. Like both Saturdays and Sunday. This time I was working for almost seven and 8 hours. And today it was off of my maid, so it was house job duty. Like did everything from uh, those utensils things and cleaning everything, cooking 4 5 times for my son, feeding him. And feeding him is such a task because he likes to run here and there, and then I have to run behind him to eat. Like very fulfilling from the heart, and I love doing my housework as well. But yeah, it does get tiring, and so my off has basically gone, and I'm back to the work week from tomorrow. Yeah, tough life, hard life, but I know a lot of people have much difficulties in their life, so this is not exactly hard and tough as it may sound. Probably it's just tiring, that what I mean to say. But anyways, I'm grateful to every bit of it. And yeah, one interesting incident that happened that I wish to share, and you can also share if you feel sharing about any interesting incidents. Just very quickly, I'll do that before I proceed to the question. So I'm in between changing of maids, and I'm going to have a very hectic couple of weeks. So I'll be just cooking for my son, and I don't have time to cook for me or my husband at the moment because too many things are going around. So just got a tiffin service. One of the things blessed in Dubai that we have Indian food, vegetarian food available, and good food. So the guy came to deliver, and he was like, when you had called, the name appeared. You know, here you have to register your names with the SIM, and even an unknown number is calling, you'll get the name of the person who's calling. So my name's of course registered as Dr. Garima. So when he came to deliver, the delivery company had given him my number just to make sure he delivers in the right location. So he came, and he seems like a young chap, like around 28, 29, those delivery guys. And he was like, just as he handed me over the dinner, and I was just about to close the door, he was like, "Can I ask you one question?" I was like, "Go ahead." And he was like, "I saw your name as a doctor, and I Googled you up, and you're a dentist. So I really want to ask you one thing, and can you help me with that?" I was like, "Sure, go ahead." And at that time, I was wearing that apron, which was completely dirty and wet because I was just washing the utensils. My hands were all soapy. So I was like, "Yeah, please go ahead and ask me. Let's do a consultation on the door." So he just lifted his lip up, and it was one of the ADC question like pictures. All his cervical area of the anteriors were deeply carious, like a proper class 5 cavity, not due to erosion but due to caries, and all like 6 of them. And in fact, one of his laterals was like half gone. So what was my first question? It was, "Does it hurt?" And he's like, "No." And I'm like, "Shit, that is not a good thing, because with such deep cavities you should be having pain. If you don't have pain, then probably there is some problem with the vitality of the tooth, which means my treatment goes more." So he's like, "Can you give me really a good discount and help me, because at the moment they're not hurting, but I can see them breaking down. So what if I don't do anything?" I was like, "No, you can't do that. If you don't do anything, then your teeth will break, and you're a very young person, and you should get treatment done." He's like, "But I don't have the money." You know how delivery guys, they get paid like max 2,500 to 3,000 dirhams a month, in which they have to, have the rent, they have to pay the rent and the other things. Barely these guys are able to save basically 1,800 to 2,000 dirhams, and of course, he cannot afford the private dental treatment out here. So I was like, it's like, unexpected, and I was like, "You know what, I'll do it." For me, I feel helping and charity should not just be about giving money. Like it's not like you go to a temple, or you just give the money and you feel that you have done your part of charity and you're done with it. I feel charity is also giving out a service, a genuine service with no expectations. And once a month, anyways, I do it for special needs children. Like actually, for all special needs children, I do not charge any treatment fee except when I'm working in a hospital where they pay the hospital fee, not mine. So for special needs children, always it's free. But then why not extend it to guys who just walk up my door for delivery and just find out that I'm a dentist and can you please help me types. Um, okay, fine, let's do it. So what I'll do is next time when he comes, and probably I'm going to see him next week, and I'll take his intraoral pictures and I'll share it out here, and I'll make an ADC question out of it, and I'll ask you questions on it, that which investigations I did first, and let's take an X-ray, and let's see if we can actually give him a good smile. Let's see how it goes, basically, because I have to talk to the clinic. They're not my clinics. I work for them, and I'll have to make a special request and tell them, what, let's not charge this guy. So, anyways, yeah, thanks. So you just so then when I went back to washing the utensils again, I was just like, I'm grateful that God has granted me an opportunity like this, which came as a surprise. Yeah, like thanks that we have the skills that we can actually give help, and we are in a position where people ask you for help. So very very grateful for that. So anyways, on that good note, share me your fancy requests like this, I would say, in your life, and where did you encounter them, and what did you do about it, and how did it make you feel. And let's get back to the question. Yeah. A 44-year-old patient requests a restoration for his missing upper teeth. Okay. Clinical examination shows first and second premolar on the right side, and he has a cavity in the lower first molar. You decided to make an FPD to restore premolar space. So both the premolars are missing on the right. Okay. So since the periodontal condition of the rest of the teeth seems acceptable, abutment teeth are not tilted. Abutment teeth, which are the abutment teeth here, canine and the molar, with RCT on the canine tooth and good oral hygiene overall. So already it has been decided that you would be doing FPD, so no other treatment option comes in choice. So now you have to think and channelize your brain towards the requirements of FPD. You also have been given the information that the abutment teeth are not tilted, they are straight, and the abutment teeth in this scenario are the canine and the molar, 3 and 6, out of which canine is already RCT treated. Okay, so you're going to drill that RCT treated tooth, and you're going to drill that healthy molar out there. Let's see what are the questions. What is the most important factor for this type of treatment before you decide on it for this case? So what is the most important criteria? What is the keyword here? If you would have seen most of my videos, you know how much I stress on the keyword and how that dictates how I look at the question. So most important factor, when the question is saying that, it means all the options are important. All the options are correct, but I have to choose the most important one, like most. So what is the most important factor? Degree of resorption, occlusion, length of the span, cost of the treatment, patient wish. Okay, patient wish, it's already been decided that we are going for FPD, so it's already been taken care of. Cost of the treatment, that has also been taken care of because the treatment is again decided that it's an FPD. Length of the span, occlusion, and degree of resorption. Now when you come down to occlusion, the question is not mentioning anything about malocclusion. It says the teeth are straight pretty much. Occlusion is kind of taken care of, plus 2 teeth are not there, so whenever you're going to give it, the occlusion in that side is going to be established anyway. So since the question has not mentioned much, I'm not going to go with it. My confusion would be between A and C, length of the span and degree of resorption. Now length of the span, 2 premolars are going to be supported by 1 canine and 1 molar. Now Muller-Dewan's principle, no, not Muller-Dewan's principle, Ante's law. Yeah, Ante's law. The perisegmental area of the teeth to be replaced should be less than the perisegmental area of the abutment teeth. So the combined perisegmental area of canine, which has a long root, and a big molar that is 6, which has 3 roots, is greater than 2 premolars root perisegmental area. So length of the span is not an issue here. If the 6th molar was also missing and you were giving a big FPD resting on canine and tooth number 7, that's the 2nd molar, then length would have been an issue, right? So here length is not an issue. Degree of resorption, great. Now see what happens if the teeth have been recently removed. So this is canine and this is molar, and the bone level is straight, great. But if there is an arch form like this, like the bone has resorbed, then what will happen is the canine and the molar are here, and when you're going to give the premolars as pontics, there'll be gap here because the bone has shifted ahead and a lot of food is going to get stuck. So you have to make sure that the bone level is same as the level of canine and the molar. So degree of resorption will matter a lot. If there is a huge degree of resorption and you think even after giving the FPD there will be space between the pontic and the ridge, then your FPD is not a good option at all. Then you have to probably go for an RPD or do some bone augmentation and do implant, etc. So my degree of resorption matters a lot because I don't want my abutment teeth to catch caries because there is gap between the pontic and the ridge. You get my point? Yeah, so the answer is degree of resorption out here. Now, why is it advisable to try in the metal framework before adding porcelain? Okay, so they are going for a PFM bridge. They are not going for a porcelain. See, this question, who does PFM anyways nowadays? Like 15 years ago, PFM were done. Everybody opts for monoblock zirconia crowns. Nobody does PFM, but Australian people do it, so you should know it. So anyways, what is PFM? It is metal fused to porcelain. So first you have a metal framework, the lab will send, you will check for the clearance, you will check if the fitting is fine and it's actually adhering, the coping, it's called as the coping, is adhering to the tooth structure. Clearance is there from the interocclusal and interdental also, like between two teeth. And that is what you check it for. And then you return it back to the lab and say, okay, please proceed. And the lab proceeds and adds on porcelain to it, like it paints and creates a tooth structure. It sends it back to you and then you fix it. That's PFM. So why is it advisable to try metal? Like, why not directly just go for the metal fused to porcelain and did not have a try-in? So why do you do it? To check for the occlusal registration, to give a temporary prosthesis. It's not a temporary prosthesis. To adjust occlusion and evaluate fitness of the framework. Porcelain cannot be tried in the mouth. You can, but it has chances of cracking. It's not like you can't. All of the above. I'll go with option C because it is to adjust the occlusion, because if there is not enough clearance, you'll have to trim the tooth a little bit and evaluate the fitness of the framework. It should be pretty much fitting except on the margins, because on the margins the porcelain is gonna come, but just like 1 mm away from the margin, the coping has to fit nicely. So the answer is C out here. New graduates, I don't know if you do PFM anymore. I mean, have you done it? I mean, or do you directly jump to the EMAX and zirconias? If you have not done PFM, it's difficult for you to understand this, but what I will suggest is pause this video, go online, YouTube, how porcelain fused metal crowns are done, check the history of dentistry, which was pretty recent, but then yeah, it's historical now, and learn how to do it because you might be doing that in Australia. Now, mechanical failure of the bridge occurs due to, what is the key word here? Mechanical failure. How many types of failures are there? There is biochemical failure, there is mechanical failure, there is chemical failure. So mechanical failure will always be because of the mechanical components of the material. Chemical failure is related to the cements that we use to glue it, okay? And bio failure is because of the loss of vitality of the tooth itself. Understand? So when I say mechanical failure, I'm just relating to the components of the framework and nothing else. So fracture of the casting is absolute mechanical failure. Secondary caries is biofailure. Periodontal disease, biofailure. Loss of vitality, biofailure. You get it? And if it was loss of cement due to solubility, it would be chemical failure. So fracture of casting is the mechanical failure. Straightforward question, straightforward answer. Don't have to think about it. Within 20 seconds, I solve it and I move it to the next one. The patient points to his lower molar cavity and you decide to place a pin retained amalgam restorations. Wow. Who does amalgam again? Especially pin retained amalgam. My god, it gives me headache. So where are the inlays? Where are the onlays? Where is composite? Where is light here GIC? Out of all this material, Australia wants you to place an amalgam, and that too a pin retained amalgam. Okay, honestly, I've myself never seen pins. I've done amalgam restoration in my 3rd and 4th year BDS. That's it. That's it. Never touched amalgam until recently when I gave the ADC exam. And I cried about it, and I've made a video about it, and I've shared it, right? Why would I do amalgam? No. But Australia wants you to do it, so you need to know it. So there is amalgam. And then when there is a loss of tooth structure, like a lot of tooth structure is lost, you need retention. Retention means you need an extra hand of support. That extra hand of support is the pin. So what you do it, you insert the pin in the dentine for at least 2 mm. There are 2 ways of inserting the pin. Actually 3 ways. But the majorly common ways are cemented pins. But that you use only in root canal treated teeth. You don't use in a healthy tooth. So if the tooth is not root canal treated, you will probably not use a cemented pin. You would most probably use something which is going to interlock itself in the dentine, and that is a self-threaded piece. So imagine a screw which has threads, and you are inserting that in a wall, and you're screwing it and screwing it and screwing it, and you push it more. So what happens when you are screwing it and screwing it? It's just getting stuck in the wall, and it's very difficult to come out because it's threaded, right? But then what it also does, it's kind of crack the nearby area, right? It's just not going to go in smoothly. So when you screw it like in this motion, it's cracking the nearby area. Now imagine a tooth which is already half destroyed. It has a big dentin exposed, and you're putting that pin, the threaded pin, and you're screwing it. You're further creating micro cracks in the dentine. So you're compromising the strength of the tooth just to increase the retention for the restoration, you know. So what do pins do basically? It provides you retention, but it takes away the strength of the tooth. So that is self-threaded pin. And there is something called as a friction locked pin, which is another thing, but I don't think so anybody uses that anymore. First of all, nobody uses pins anymore. Australia does. But in a healthy tooth, you go with a self-threaded pin. In an RCT treated tooth, you go with a cemented pin. Why? A tooth which is RCT treated already is already weak. So if you're going to use the self-threaded pin, you're going to further fracture that tooth absolutely. So you'll create a big vertical fracture in a tooth if you're trying to give a self-threaded pin in an RCT treated tooth. But a healthy tooth, you go with, you think, I mean, of course, the strength of the tooth is a little bit more because you have not removed the dentine while doing the RCT preparation. So the tooth can withstand that amount of loss of strength for gaining the support for the restoration. You understand? So pin retained amalgam in a healthy tooth is always self-threaded. So now let's go and see the question. So pins often. So the question is asking, what do pins do? It's a dental question, not related to this scenario, except for the fact that you're going to place a pin on a healthy tooth. Increases the compressive strength and decreases the tensile strength of amalgam. It decreases both the strengths, compressive and tensile. The strength of the restoration is heavily decreased. Only the retention is increased, remember this. Decreases the compressive strength and increases the tensile strength of amalgam. Wrong. Decrease the compressive strength and the tensile strength of the amalgam. Have no effect on the compressive and tensile strength of the amalgam. No. It's option C. It decreases both the strengths. Straight and simple. If there was an option which said it decreases the strength but increases the retention of amalgam, that would be my perfect choice of answer. So understand this. The priority should be decreases strength, increases the retention, and then it decreases strength, both the strengths, like that. So read more on it. Again, pause the video, go see amalgam, see pins. Now the best pins type to be used are self-threaded, always. They are the best ones. After that, I would go with friction locked. After that, I'll go with the cemented or the resin retained one. Cemented and the resin retained are the same things. They are not different. So self-threading, friction locked and cemented. Why the cemented is the last one? Because you just take a glue and you kind of fix it. You take a cement and fix it. It can easily come out because the cement can dissolve, the bond strength could go, anything. But a self-threaded one is very difficult to take it out because it's threaded itself in the dentine, and it's got a lot of dentine between its threads, and no cement is used, so it's like a very strong connection. So yeah, I finished this question based on amalgam. Definitely you'll get a question in ADC part 1 about amalgam. 110% you are going to have an amalgam task in your part 2, so you'll have to learn more about it. And you can also get in your communication OSCE a question on amalgam. So amalgam is a very loved topic by ADC examiners. All the dentists that I've asked in Australia that I know of, nobody uses amalgam, but ADC examiners love amalgam for some purpose, and because you are going to give that exam, you need to know about it. So read, go ahead. So yeah, leave me your comments, and hopefully you have understood. Again, your comments mean a lot to me because they motivate me. As you all know, I shoot these videos just to help you all, and there is no other purpose apart from that. So, and it's nice to connect to you all when you leave comments. So see you next time. Bye bye.